All right, we can go ahead and get started. So, good afternoon, everyone. Welcome to today's panel discussion, Ensuring Equity in Telemedicine for Older Adults. So glad everyone could join us. My name is Mario Rubano. I'm a policy associate here at the Center for Healthy Aging at the New York Academy of Medicine, or NYAM. And for those of you that are perhaps unfamiliar with NYAM, we're a public health institution currently celebrating our 175th anniversary. And our mission here is to drive progress towards improved health through attaining health equity. And today's event is squarely aligned with that goal. And here at the Center for Healthy Aging, one of the many initiatives within NYAM, we work to improve the health and well-being of current and future aging populations. So just a quick note before we dive in, we ask that you please mute your microphone. We opted to do a meeting style format to make the event a little bit more connected as opposed to the webinar format. But with that comes the added burden of making sure your microphone is turned off. So we really appreciate that. So we've brought together 4 experts that'll bring a variety of perspectives to the emerging challenge of maintaining digital equity for diverse older adult populations. So we'll hear from the clinical or provider side of telehealth, the older adult patient perspective, policy and regulatory considerations, and everything in between. So internet use and access to broadband among older adults, it's been found to vary widely according to age, education, household income, race and ethnicity, with older, less educated, lower income, and non-white individuals tending to lack all of these vital resources. Of the many aspects of our life that the COVID-19 pandemic flipped upside down, telehealth is among the most significant, and I guess time will only tell the longer lasting effects that'll be with us for a little while. So as modern medicine adapts to some of these changing models in healthcare, it's critical that stakeholders work together and problem solve and meet all of these varying needs for older adults and ensure that this new paradigm is firmly rooted in equity. So I'd like to toss it over to Greg Link. Greg is the Director of Caregiver and Supportive Services at the Administration for Community Living. He'll provide a brief bit of context on the panel discussion as it relates to the work of the Older Adults Equity Collaborative, the ACL-funded initiative at the core of today's event. So the floor is yours, Greg.
Thank you, Mario. Thank you for that introduction. And thanks to the New York Academy of Medicine for convening this really timely webinar on such an important topic. For those of you who are watching but might not know, NYAM's been a grantee of ACL, particularly of my office, for the past 2 years. And as Mario mentioned, they are part of an initiative that we call our Older Adults Equity Collaborative, which consists of a total of 6 grantees representing various underrepresented and minority populations of older adults and family caregivers across the country. And NYAM plays the role of the coordinating center in helping to bridge the work of these 6 other organizations, as well as taking the initiative to provide direct technical assistance to the Aging Services Network on a variety of topics. And this webinar today is exactly one of those things that they are doing to really advance the work of equity in the older adult and family caregiving space. So the overall project of the Older Adults Equity Collaborative really works to increase the cultural competence of the Aging Services Network to better meet the needs of older adults and family caregivers. These grants are funded under the Older Americans Act, which, for those of you who are familiar with the Older Americans Act, has a particular mandate to direct attention to older adults and vulnerable older individuals who come from limited English-speaking populations, those of lower socioeconomic status, and those living in rural and frontier areas. And as an agency, in particular, the Administration on Aging, where my office sits, has long taken seriously the importance of ensuring equity and equitable access to healthcare and all forms of services and supports. And the current administration has also made equity a priority in all of the work that it's doing. As Mario also mentioned, the pandemic that we're still in the midst of, but hopefully moving out of, really underscored some of the extreme inequities that exist within our society. We saw firsthand how the pandemic disproportionately impacted those older adults in lower income areas, and those who were already isolated to begin with became further isolated as a result of quarantines and the like. And it just further highlighted the inequities that exist in the older adult population. We also saw how family caregivers undertook even greater responsibilities during the pandemic, often having to give up jobs and more, sometimes to step in to provide support of loved ones impacted by the pandemic, those who came out of nursing homes, and those who were unable to have any other form of support. But as with everything, I think there can be a couple of silver linings, and I think that is the case with the pandemic. During the height of the pandemic, we saw the critical value of technology and how it revealed itself more clearly than ever as a result. To be sure, many of us learned that we can work quite well remotely from anywhere, anytime, and have a better balance in our work, between our work and our personal and home lives. And what seemed like a novelty just a few years ago, like undertaking extremely complex projects and meetings without ever being in the same room with those you're working with, are now a fairly commonplace. And I think a lot of us oftentimes wonder, are we ever going to go back to 100% the way things were? Telehealth was one of those things that really gained in acceptance and momentum during the pandemic. For many of us, we were able to keep up with our basic healthcare needs by getting on a video call with our doctor or nurse practitioner to address some of our basic health concerns. However, for many older adults who lack access to broadband internet or the means to obtain and use the technologies that actually make telehealth possible, this new part of our reality is basically inaccessible to many. And so today I'm really looking forward to hearing some of the discussions around some of the myths and false assumptions that exist around telehealth, learning more about what both patients and providers need to more effectively and equitably access telehealth options, and then a discussion around some of the policy and infrastructure implications needed that we can really make this work well for older adults, seniors, people with disabilities, the range of populations that ACL serves. And so Mario, I'm going to throw it back to you, and I'm really looking forward to the discussion today.
Great, beautifully put. Thank you, Greg. So moving forward, we're just going to launch into a quick poll question that'll help us get a sense of some of the sectors that are in attendance here at the event. So you can take a look here at some of the options and just select one that best fits with the work that you do. And we'll just see how that kind of spreads out. All right, about 20% apiece for clinical and aging services, some representation in public health, kind of leading the pack. Great. This gives us a good sense of who's here to kind of engage in this conversation. All right. So for a second question, we wanted to get a general sense of the attendees' opinions, experiences, and preferences regarding telehealth. So if you'd like to, feel free to share some of your thoughts in the chat box and see where some of the other attendees align, see if there's any similarities. And as the event unfolds, we encourage you to drop any questions into the chat box. While we may not have time to get to every question before we close up, we will make the effort to follow up on some of those questions that we're unable to get to. All right, so now for the main event, we're gonna pass this over to do some quick introductions. I was thinking we could start with Darcy.
Thank you so much, Mario. Good afternoon, everyone. And I guess maybe good morning if you're on the West Coast, but my name is Darcy Graves and I'm with the CMS Office of Minority Health, where I do a host of different things related to health equity, including helping to manage a large portion of our rural portfolio, which is inclusive of rural frontier tribal nations and the US territories. But I was thrilled with with Mario and ACL's opening, because my background is primarily in culturally and linguistically appropriate services. And so that's what I've spent the better part of the last 20 plus years doing, is working in that field across geriatrics, public safety, domestic violence, and a host of other topics. And I'm thrilled to be here with you all today. And I'll pass it back to Mario so you can meet the rest of my esteemed panelists.
Great, thank you. Dr. Weisman.
Thanks, Mario. Hello, everybody. I am Matthew Weisman. I'm the site chair of medicine at Mount Sinai Beth Israel in downtown, which is the campus of Beth Israel. That's the campus of Mount Sinai below 34th Street.
86000.
Somebody's ringing in the background.
There we go.
I'm trained in primary care. I did a combined residency in internal medicine and pediatrics, and I still see primary care patients, in addition to overseeing a pretty big cohort of faculty and trainees, residents, and fellows here. And before I came back to the Mount Sinai Health System about 4 years ago, I spent a long time in the federally qualified health center world. So lots of time dealing with patients in an urban setting, but many of whom were unserved or underserved and on Medicare and Medicaid, and trying to think through access to care challenges for them. So thanks to NYAM for inviting me, and pleasure to sit on this panel with a great group of colleagues. And Mario, back to you.
Thank you, Dr. Weisman. William. Oh, you're on mute, William.
Sorry about that. Yeah, I was on mute. Can everyone hear me? Yep. So very good. So my name is William Hamer. I'm the executive director of a not-for-profit group here in Central Harlem called Harlem Advocates for Seniors. We are a group that provides program support and services to residents living in Harlem. We currently do that. We do that at 3 different sites in Harlem. And we have a model and a mission to take services and programs to where seniors are, or preferably older adults. We found out that most of our older adults do not go to senior centers, and they still need the kind of program support and services that you could find and be provided at a senior center. Just quickly, we have been a partner with NYAM for several years now, and we were fortunate to be able to get a grant because we went through the COVID experience as a not-for-profit who did not pre-COVID even have a Zoom account, to an organization that had to quickly, jump into the Zoom world, put as many programs as we could as possible online, and then realized about the inequities because so many of our older adults could not access the programs and services that we were providing. So we quickly, through the support and auspices of NYAM, we were able to receive a grant to put in place some technology and computer training, which we're currently doing now locally at 3 different sites. And I'll talk a little bit more about that later in the program. Thank you.
Beautiful. Thank you, William. And finally, Dr. Knudsen.
Thanks. Hi, everyone. My name is Janine. I'm joining you all as a medical director from Allied Care Solutions. And we'll also be speaking to my history working in New York City at the Health and Hospitals Safety Net System and also in the Public Health Department. And I'll say I'm equally thrilled to be here with this esteemed panel, but also to learn from all of you, because telehealth feels both like it's been here forever at this point, but also like there's so much left to learn and so much work to do to make it equitable and to really design it in the way that we feel like it needs to be done. And I'll speak to my experience building out telehealth for health and hospitals during the pandemic, doing some work with the health department in terms of getting communities access to healthcare through telehealth and other means at the health department. And now that I'm at Allied Care Solutions, we're a company that's actively building out virtual care for Medicare members, and really thinking through how do we leave no one behind? How do we design care models that are virtual that really uncover barriers to telehealth and address them directly? So very excited again to learn from you and all of you in that journey.
Lovely. All right. So I'd like to begin this conversation with the concept of assumptions, specifically the often ageist assumptions that we tend to make concerning older adults. And assumptions are entirely normal to make. We make them every day, often unconsciously, but they can certainly influence the work that we do. And in the context of health, the care that we provide. For example, I'm a millennial, a digital native, yet I personally always opt for the in-person doctor appointments, even if it's the 8 a.m. slot. I just prefer the physical aspect, the connection. That's not exactly what you would assume given my generation. So could we, kind of in that vein of assumptions, what expectations tend to be made about older adults' preferences regarding telehealth? Perhaps we could start with William. If you could speak to some of what you've seen in the Harlem community.
Well, let me just quickly say that I think I come from a fairly unique perspective. And one is as executive director of an older adult organization, but also someone who is comfortably into older adult years, who also is now doing telehealth. So I would say that from the perspective of the folks who we work with, the real issue and question that I think is the bigger question is, how do people get access? How do they get trained? And you know, to use the technology? That is a big issue that I'm sure is a focus of many of this panel. But for me, once you have learned how to use the technology, I ask the question, why did anybody want to go back to a hospital? You know, I mean, the fact is that you go to a hospital to visit a doctor who, if you're lucky, if you spend 15 minutes in that conversation at the hospital. And when you think about older adults who have to travel to get to the hospitals, oftentimes an hour away or more, access a ride, et cetera, waiting in waiting rooms, sometimes for appointments that are an hour or a half hour late. I think that the importance of telehealth is just really should be blown right up. I mean, I opt right now for all telehealth appointments unless there's some particular reason I need to go to the hospital. I talk to my doctor, hey, let's get on a telephone call or a telehealth call, because what, 15 minutes? And so again, and that's what I'm seeing. I'm seeing that I think older adults are really eager to learn technology. And I think the more they learn and we educate them on the use of telehealth, I think many of them will be opting to do what I'm doing. You know, let's just do this 15-minute visit and we're good to go.
Great, thank you, William. Janine, I know you had mentioned in some previous conversations that you came to see that older adults were pretty motivated by smartphones as a medium for this telehealth connection. Could you talk a little bit about that?
Yeah, happy to speak to that. And this is where I want to give credit to this really important research survey that my colleague Jen Lau conducted at Health and Hospitals, even pre-pandemic, to really assess what patients' interests were in telehealth and how they'd like to engage in it. And the survey showed that all of our assumptions were completely wrong, that people with English not as a first language, older adults who we thought might be less excited about engaging through a tech platform, they were all really excited about this opportunity to do telehealth. And again, this is pre-pandemic. I think excitement has only grown. But there was that interesting caveat that has now played out very clearly during the pandemic, that in the last few years, that they're more likely to engage through a smartphone or a telephone visit, less likely to be doing it through a laptop or a desktop computer. And so that was really, really important knowledge to make sure we're designing telehealth programs and telehealth models that can be done via phone or smartphone. A lot of text message, a lot of sharing links using apps, things like that. So really having that information about what people were looking for before designing programs was so important. So I now think of that like every time we're starting a program to really get an understanding of what patients are looking for.
Got it. Thank you. Any other panelists like to jump in on that?
I mean, I'd be happy, or either way.
Yeah, go for it.
Dorothy, you first.
So just to connect some dots from the provider side, and since I'm from CMS, I have to first say, when I'm talking about telehealth during probably the bulk of today's presentation, I'm talking about it kind of just generically and not regulatory or statutorily, because what gets reimbursed for telehealth and what we're calling telehealth may or may not be synonymous. So, first those caveats, but I think I think people have pointed out a lot of great benefits to telehealth, but I think as we're thinking through some of these pieces, it's in addition to what Janine was saying about, people using smartphones, it's thinking about, who can afford a smartphone, who has access to broadband, how many minutes do you have if you're on a minute plan, and if you're on a minute plan and you have kids who are also trying to do remote learning while you're trying to get a remote visit in, what does that all mean? And then also thinking about some of our William made a great point about, not wanting to drive an hour plus to get to a provider. When we're looking at our rural frontier tribal nations, US territories, that's huge. But it also, that distance piece from a transportation standpoint, but it also may mean that broadband hasn't gotten to you. Like it may go up to the reservation line, or there's 34% of rural counties that don't have fast enough broadband to qualify for traditional Medicare telehealth. So it's this both and. I think we've seen a lot of great assets and benefits, but I think we have to be, I love the fact that you're talking about not leaving anyone behind, because I think we have to make sure that we're not looking at telehealth as the panacea that's going to fix it all. But we do need to be cognizant as we move through that process. And that was a little longer than I intended, but thank you very much. And I don't know if Dr. Weisman has anything to share after that.
No, thanks. That was great. And a lot of the points I wanted to make. I mean, I think at the beginning of this, I really did assume a bunch of things. Like I assumed, like William, that everybody would want to go. Like, why would you want to come to the doctor's office? And I thought that telehealth would solve a lot of problems. And even pre-pandemic, we spent a lot of time trying to convince people to use more and more telehealth. And we got pushback from a couple interesting places. I mean, we got pushback from some of the doctors who felt like it was either less good care or it was standing in the way of a real doctor-patient relationship. Somebody stood up in the back of one of these lecture halls where I was speaking about telehealth back in 2019 and said I was killing primary care by even suggesting that people should use telehealth. There was concern about reimbursements, about liability. And I mean, some of those things are still here, and I'm sure we're going to talk plenty about that. But I was surprised by how much pushback there was on the doctor side at the beginning. And I spent a lot of 2019 trying to undo that. And I also thought it was going to be sort of a panacea for people who were older and had trouble commuting, who couldn't afford to commute, who couldn't take time off of work, who couldn't get babysitting or, care for their parents or whatever, and couldn't get away to be able to come into the doctor. And I was sort of surprised, and I think this is what Darcy said too, at how many barriers, even in New York City, around broadband, around having enough devices, around having enough space in your apartment to be able to get away from people, to have a private conversation. And we've done plenty of video visits with people standing on the street, in their bathroom, in their car, as a way of getting away. And so as we're thinking through sort of my early assumptions, some of it is, we got over the hump with the doctors. We got over the hump of people who were scared to try it, although there's lots of data from pre-pandemic saying people really wanted to try telemedicine. And now, as a bunch of people have said today, how do we really sort of optimize all those requirements so that people have what they need to really do a good job of telehealth?
Great, thank you very much. So on this idea, to kind of like pull this thread a little bit on barriers, I'd like to move on to digital skills. So this concerns the importance of developing basic skills for older adults, as well as the skills of providers. We can't forget that providers need to ensure that they've honed their telehealth skills. And Janine, you'd mentioned some innovative training models that you've seen at NYU. I thought you could kick us off with that.
Yeah, happy to start with that example, although I will say it's obviously just one piece of this very large pie around skills that both the care team needs and that patients and their caregivers need. But I was very excited to learn about this program that's being piloted at the NYU School of Medicine around standardized patients, but applying them virtually. So it's important to recognize that even though providers may be tech savvy, that doesn't mean that they are born with the skills they need to connect with someone virtually. And I think I heard Dr. Weisman mention relationship building, maybe that was Darcy as well. That's such an important piece of telehealth and something we're all learning how to do is building relationships virtually. So this NYU program has standardized patients, which are trained actors who will engage in a virtual visit with a provider and then give them real-time feedback. There's also a secret shopper option that can be done. But the point is really that providers need coaching and feedback around providing good telehealth. And most of us just need to be humble, recognize that, and recognize it's potentially a lifelong learning process that we just need ongoing feedback. And so I think I hope I would love to hear William's thoughts on this, but it's just so important to have the patient perspective in mind that they may experience things very differently than what we think. And so it's important to keep that assess that in many, many ways.
You want to take that, William?
Yeah, I just have a quick question. This is just for my own edification and may be helpful to the rest of the participants. In terms of telehealth visits and in-person visits, is there a differential in pay for one versus the other? Because I was thinking about that in relationship to if we're trying to drive telehealth visits and we're trying to get more people online, are the hospitals and doctors receptive to that? One, in the sense that they're getting the same level of reimbursement for the encounter, or is there a difference in pay scale that might also drive some policies that may not be totally helpful? So again, I don't know if Darcy, that's a question from CMS, or Dr. Weisman or whomever, but I think that would be interesting for the panel and the participants to know.
So the short non-news making version of my response is it depends on the services and your geography and who your payer is and all of those things. And then I will pass it over to the healthcare providers on the panel to offer some additional specificity to that.
Dr. Knudsen, do you want to go first?
No, please. I do have a comment after you're done, though.
I was just going to say, first of all, thank you to CMS, which I don't always get to say. I think CMS has been amazing at relaxing a bunch of restrictions over the course of the pandemic to facilitate reimbursement and releasing regulatory pressures during the public health emergency so that we can really carry out telehealth in a way we never thought possible. And I'm hopeful that a lot of those things will continue after the public health emergency. I won't dare put Darcy on the spot and ask her about that, but I think it's really important, and it's on all of us to sort of advocate for ways to facilitate telehealth, not just in rural locations, not just video only, not just reimbursed at a different level, and with sort of interstate flexibility, and we can talk more about that later on. So thank you for that. The other question that's in my mind that I don't have a good answer to is I think a lot of people thought, like as urgent care centers popped up in New York, that the goal is to take away emergency room visits with urgent care centers, for example, and sort of lower the total cost of care. It's not clear to me that that's totally panned out and that some people are using urgent care centers who would have otherwise used no care, done a free phone call or looked it up online. And I worry the same thing about telehealth. It's great that right at this moment it's reimbursable, and it's great that it can replace in-person visits for lots of different diseases, for lots of different patients. I just don't want it to be an add-on service that increases the cost of care, because now anytime a question pops up, I can just, Zoom my doctor. And figuring out how to manage that as a public policy thing way outside of my scope, but it's really important in thinking through how to make this sustainable.
Oh,
And
very
the one
important.
thing I'd add on.
Go ahead.
Oh, sorry, Mario. The list of considerations is long, and I don't know that we want to go too far down the rabbit hole of payment, but There's one other piece I wanted to add on that maybe ties back to the amazing work that William's group is doing, which is we have to think about what, there's been incredible progress in telehealth payment. It's paying for a lot more than Medicare and other groups are paying for a lot more than they used to, but there's certain things that they're not paying for, and we need to keep shining a lens on that. And the one that was really our sort of Achilles heel when we were trying to switch to telehealth during the pandemic at health and hospitals, and continues to come up now, is navigation services. So we can't just assume that if someone gets a link to a video visit and that's enough. And I think I'm preaching to the choir here. We know that some patients, some people, providers and patients may need more coaching around how to access telehealth. They need someone to come to their home with a device. They may need help handling their patient portal afterwards to send messages to their provider. And providers need time to participate in that coaching work and the work that happens outside of the visit. And there's no, this is maybe not a unique to telehealth problem, but it's a big one to tackle, to think about what kinds of supports do we need to make telehealth successful and equitable, and then how do we pay for them? And again, I keep thinking of William and the amazing work that his group does, which is a lot of it is navigation services, and that's so important.
Yeah, and Mario,
Go ahead.
Put
Certainly.
a bow on a part of this. One, thank you, Dr. Weisman. I don't do anything to do with any kind of payment policy, but I will take kudos on the behalf. I think it's always important to remind folks, and folks may know this, but CMS doesn't get to wave a lot of magic wands and make these decisions. These decisions are given to us by, as we say in the DC Metro, those on the Hill. Changing what gets reimbursed by telehealth and what telehealth includes is literally and figuratively frequently an act of Congress. So those are important pieces to remember. Just from CMS can do a lot, but we also have to have the authority in which to do it, or the lawyers get involved. But I did want to highlight two resources when we're talking about navigation and we're talking about rapport building and we're talking about all these different things. There's two resources that my office, the CMS Office of Minority Health, put out. I want to say it was early in the pandemic, but time is weird these days. So there's resources for patients, and then there's also resources for providers. And the resources are written in plain language and are intended to help both providers and patients figure out how to use telehealth. The patient one is telehealth, what you need to know for your family, and it walks you through all different sorts of steps. The other really exciting piece about this resource is that it's already been translated into a host of languages. The patient version is available, and I never remember them all, so I'm staring at my other screen, so I apologize, but it's available in English, Arabic, Chinese, Haitian Creole, Korean, Russian, Spanish, and Vietnamese. And we're working on adding additional languages as they pop up in our populations. But all of those are there. You can download them. They're all free. You can print them out. You can frequently request printed copies be sent to you for no charge. And then there's also resources for providers. So it's, I'm always loath to come on a panel like this and say, here are all the problems and here are all the great things, but not provide, a takeaway, or how can we, what else can we do other than, this amazing knowledge that I now have. And so hopefully this resource is helpful in that vein. Okay, thank you. And back to you, Mario.
Oh, terrific. This reminds me of a term that's oftentimes employed in this digital equity space. Digital literacy. I'm sure we've all encountered it. And actually, it's in the chat. So that's a term that seems to sum up the concept pretty effectively. But I recently heard some convincing pushback against using that term, with the idea being literate or literacy, especially in the United States, having a deep, complex, and often harmful political history. And it wasn't until the Voting Rights Act in the mid-'60s that literacy tests were actually outlawed. So this is still pretty fresh historically and culturally. And I don't know if anyone wants to add on to that, but it was a recent learning for me personally that I wanted to share out. It was just, it caused me to kind of stop and reflect. I just wanted to pass that along as well.
The only thing I would couple with that is, because when we're talking about, especially when we're talking about digital literacy in this instance of just going online and navigating to get on a telehealth visit, but there's also the digital literacy of having a website to get healthcare information or figure out how to schedule a healthcare visit. And then there's the health literacy that couples with all of that. So you have literacy, digital literacy, numeracy, and digital, so it's all piled upon each other.
Right, and I was going to add, like, if only 11%, I think, of Americans are healthcare literate, and so we end up, writing stuff in plain language and finding other ways to do, teach back and all these things to make sure people really understand what we're trying to say, like writing the CMS handouts in plain language. And I feel like the same thing is true for what we're talking about today with accessing digital health. So there are so many steps where people can get lost. And I think about that, back to William's point about, why would anybody want to come to the hospital? The one nice part about coming to the hospital is when you come in the front door, we have concierges and security and all these people who can help you get to the right doctor's office at the right time and help you check in and help you, navigate the process until you're sitting down there across from me. And I worry a lot about, and if you don't speak English, we have people who speak lots of different languages in the lobby. There are lots of ways to, as soon as you get in the front door, we got lots of ways to help you navigate that system. On the, video visit side, when people have a video visit scheduled with me, it may be that the person they scheduled with on the phone, spoke to them in Spanish or worked through the technology. Maybe that I could do that visit in Spanish, but there's a lot of steps between, getting that appointment and actually sitting down across the video window from me, where it's really easy for people, A, to get lost, and B, to have nobody to turn to help. Because they call and they get put on a queue with, 75 other people, and my visit's over by the time they get through the queue.
Yep, and I see William coming back on camera, but while that happens, just Dr. Weisman brought up, and I know Janine probably has thoughts on this too, the language at, somebody with limited English proficiency. So when we're thinking about this accessibility standpoint of this technology, making sure that whatever telehealth technology you're using has room for an interpreter to show up in that visit. Can you do it? Most telehealth things aren't set up like a Zoom meeting. It's not like it's not a party. So it's how do you make sure that you have either a spoken language interpreter available or a sign language interpreter available? And are you able, if you're on a smartphone, being able to see an ASL interpreter is hugely problematic. So, those sorts of pieces that we have to take into account and think through as well. William, over to you.
So I'm just curious. I'm not sure if that was a question for me. I didn't hear my name. I'm having some audio difficulties on my end. I'm getting a lot of crackling. I don't know if other people are experiencing that. But can you hear me clearly?
You're coming through crystal clear.
Crystal clear, but what's coming back to me is crackling, and so I'm not sure what that's about. I just have a point that I want to make. I mean, I think as we go down this track about telehealth, I think we really have to highlight the benefits. And I know that, Mary, you talked about, the in-person visit and building the relationship. But most people, how often do they see their doctor? I mean, the question is, how many visits do you have in the course of a 6-month period of time? Maybe 1 or 2, unless you have some very outstanding medical issue. I'm thinking that a relationship over time could be effectively built with a telehealth model, right, where you could actually have more contact with your doctor, which would basically be the kind of contact and connectedness that many older adults seek in terms of their medical care. And the psychological benefits of talking to and seeing your doctor on a more regular basis, even if it's a 15 or 20-minute call, is, I think, more advantageous to older adults who might only see their doctor once every 6 months or once or twice a year, unless they have some very outstanding issues. So the connectedness that could be generated through a telehealth model where you could see your doctor, a 15-minute call every 3 months, right? How you doing? What's going on? Doctor has a chance to take your issues. And many doctors nowadays can actually assess and prescribe, you know, your medications and get a real good picture of what's going on with you just through a very effective telehealth visit. So I think that's something that needs to be talked about because, as I said in my opening commentary, I mean, right now, I mean, every visit to my doctor could be a telehealth visit. I mean, I like my doctor, he's a great guy, but, you know, I mean, going to get a report on my blood tests, you can do that in 15 minutes, right? Versus the hour and a half that might take me to get to the hospital and then sit in your waiting room, you know? So again, I think that's something that I think hopefully the Equity Commission will take a look at and begin to drive that, you know, more frequency, more volume, you know, could create really effective relationships and keep older adults really connected.
That's a brilliant point. That raises to mind the effectiveness of mental health care and behavioral health through the telehealth model. I mean, the effectiveness of that seems to prove that it is totally possible to build and continue to build upon really deep relationships with medical providers and patients.
Mm-hmm.
I mean, I think the joy, you know, as you said, from the doctor's side, like the joy of primary care is building those relationships in little doses over time. And I think video visits are a great way, not necessarily the whole way to do it, but definitely a piece of that. Because I agree with you, when I see a patient and they're in person and they're frustrated because it just took them an hour to get here, and then they had to wait in the waiting room, and now their accessoride is coming to pick them up in like 6 minutes, and so all I've got is this much time with them, and they're rushed and I'm rushed, and nobody, you know, that's not good for, you know, doctor-patient relationships either. So I think to be able to extend that out over time and you know, and have ongoing relationships and sort of queue up the things so that, you know, we do blood test at home, we talk through the psychosocial stuff at home, and then when they come in, it's really focused on whatever the stuff is we can't do by video. I think it works out really well. Not for everybody, not in every case, not for every disease state, but for lots and lots of people who maybe never thought that was a good, you know, a good relationship builder.
I'll just add that what I'm hearing from you, Matthew, and also from William, are these exciting new ways that we could design care to be better, to be strengthening relationships, and to be providing more convenient care for people so they don't have to come in. When I hear waiting room, I get palpitations as well. And I think that we're just at this turning point where we just have to be careful not to just try to replicate traditional healthcare through telehealth. And I don't think this is a new learning. I think a lot of people have come to this conclusion over the last few years, but we've seen a lot of models where they're trying to do just that. They're saying you have a standard patient with your provider over telehealth, and that's it. And I love hearing the vision from Matthew and from William on, no, we can do better than that. We could do much better than that. And we need to have providers at the table to think creatively, but we, more importantly, really need to have patients and their caregivers at the table to make sure that we're designing something that makes sense for William and his community and everyone else that we're trying to serve. Because I think sometimes we get too caught up in replicating the traditional way. And that's just such a danger. We're at such an opportunity point.
Oh, so much great content there. I do want to move ahead to another topic because with skills and competency, they're all vital to successful telehealth operations. But what good are your Zoom skills if your connection to the internet is unreliable? So broadband access, it's a significant divide throughout the country, as Darcy mentioned, especially so in rural areas, frontier areas. But I'd like to dig into it a little bit. Darcy, you had mentioned in a previous conversation some new policy and regulatory developments for broadband access, subscriptions. I was wondering if you could kind of pull that thread a little bit.
So other parts of the federal government, the FCC, the Federal Communication Commission, USDA, and a few other agencies outside of HHS, which you wouldn't necessarily typically think of when you're thinking about health and healthcare and those sorts of things, are offering funding, are offering subsidies, are offering grants and resources to help individuals and communities and organizations build out that structure, that infrastructure needs. So I think, there's a wealth of things out there, but it's going to take more than just the resources of the federal government. It's going to take full cooperation and full participation of lots of people to and I'm on the same plane as Janine, in thinking in terms of, this is an opportunity. And we have to think through this opportunity so that we don't squander it, so that we don't leave anybody behind, so that we're making sure that all of the opportunity is truly seized and none of it is wasted. But I can try to pull a couple of links from those other websites and drop them in the chat, Mario.
Oh, that'd be great. So I do want to take a look over at the chat box. Looks like we have a question from Erin Ferenchik. She's curious if any providers have experience with group telehealth visits with aging patients.
Well, Matthew just smiled, so I might want to turn it to him first, but I'm happy to give some great examples. Maybe you smiled because it would be so great to try it. There's a lot of potential. I've seen it work in a few different examples, and they're basically taking group visits that were happening before COVID were happening in person and turning them virtual. I've seen it work well for behavioral health. So at Bellevue Hospital, we have very strong addiction services, and other health and hospitals in New York, very strong addiction services where group therapy is a big component of what they offer. And they transitioned that to virtual during the pandemic. And just had to make sure that they had both video options and phone options, but they were able to keep the group cohesion going of being in group therapy pretty well. And I thought that was an exciting model. To William's point, it's so much more convenient. When you have a lot going on in your life, to come in is really hard. And then I've seen it work for things like diabetes care, which there are group care models for wellness visits for older adults. It doesn't overcome the issues of connectivity and access that we've been talking about, but it's exciting to see that the group models do work. I'll say that the final example I have is not actually a healthcare example, but just a general community intervention example around loneliness. So as we know, loneliness is like a very important issue to be tackling now with everything that we've gone through for any age group, but older adults, of course, has impacted them as well. And there are some very exciting efforts to bring people together virtually to address loneliness, to foster a sense of community. And I think we think of those interventions as being more for younger age groups, but there have been really wonderful examples of virtual loneliness interventions for older adults as well. So again, this gets to our initial conversation around assumptions. We can't assume that virtual is not the right answer for that.
So on this topic of kind of hybrid design, as we kind of weigh these pros and cons for telehealth, I was seeing in the chat box, it was Holly Riccio talked about her mother's primary care doctor. that she requires that before patients come in for a physician or annual visit, they have to do a telehealth consultation. She's a one doctor practice, so I think this is convenient for patients, but also often a benefit to the providers as well. The doctor is able to get to know the patients, develop a relationship virtually before they step foot in the office. So yeah, I thought we could kind of keep playing with this idea of some of these, I guess, the possibilities, the potential for new kind of hybrid models, because it sounds like kind of what we're getting at is that telehealth isn't the panacea that we were maybe hoping it was or expecting it to be, that we are going to have to find a way to kind of balance all of these competing needs. Just wanted to open that up to see if there are any other just innovative ideas, any creative thoughts into how we could balance that.
I mean, I love the idea of that. You know, I use often when I talk about telehealth, I use these stock photos of crowded waiting rooms, and just like Dr. Knudsen said, like, you know, it gives me palpitations to think about the patients waiting out there. And, you know, when I'm in with a patient, I'm focused on the patient. And at the same time, you know, there's also the thought about all the patients who are out there who are waiting to come in. And I think that's sort of the good part, and the bad part about doing this by video is it does take some pressure off. I'm not hearing people standing outside the door eager to get in. And it does create a much calmer way to sort of interact with patients. I feel the same way about those group visits. I mean, it sounds like a great idea because there's a way to sort of have a, you know, calm, in-depth conversations. I worry, just to think back to what we said 20 minutes ago, it's easy to be a patient in a real waiting room. At least you see people coming and going, and there are people you can ask, like, am I almost up, or how long is the wait? In a virtual waiting room, it's just a black box that can be more painful, I think, than being in a real live waiting room with other people. But I love the idea of taking that visit and sort of extending it to encompass more opportunities for relationship building and for coaching. And, you know, I'd want another visit after the visit. Like, you know, what about those interventions we talked about? How are those things going? And really sort of extend the conversation over time and space, really, into the future.
Those are fabulous ideas, especially the waiting room. It never even crossed my mind. The virtual waiting room, just how barren and deserted it is, and it just seems to be ripe with potential, especially from, you know, like the UX design for user experience for all of these different telehealth platforms. That maybe there are some creative things that can be done in that space to even make the waiting rooms just less of a, you know, a patient staring at the screen. The doctor will see you soon. So yeah, that's really fun to just even imagine some of those possibilities.
I would love to see that as speaking solely as Darcy, you know, thinking about using those, you know, as educational moments, like what prevention medicine, you know, what preventive message could we fit in there? What can we remind folks about, you know, their flu vaccine or their other immunizations, or what other services they're able to access during, you know, using telehealth and those sorts of things. Like, let's go ahead.
I love that. I love that. And at the same time, I think, as somebody was just saying this morning on a call about, you know, calling into our practices, and before you could get to a doctor, you had to hear about, you know, vaccines and our EMR and all the other services we offer. And it's, you know, and the only thing worse maybe than sitting alone in a telehealth waiting room is sitting alone listening to like the video version of music on hold. So I agree, it's a great opportunity that we haven't capitalized on. We just have to figure out how to do it in a way that sort of respects the sort of like social psychology of people waiting and being anxious about waiting.
Right.
Yeah, no, I'm thinking about all the times I've been in, like, you know, I've gone from the waiting room to the clinical room, and they have these screens now that are constantly rotating information. I'm just like, how can we, you know, or, you know, what can we share during those moments that they may not hear in another time? I
love it. Yeah,
might have something.
And Scott in the chat box.
I know Mario.
Oh yeah, go ahead.
Oh yeah, well, the digital magazines, I know, I love that idea. I want to be respectful of time, but the one plug I'll make for all of this is that these are exciting problems to be able to tackle, and they're being tackled in a lot of places. So I know someone has solved for this problem already. We just haven't heard about it. It hasn't been disseminated widely. And then I just think, where do we need to look for examples of ways to solve for these issues? A lot of it's happening in the startup world with, where there's big tech teams that are able to build things quickly. Some clinics have done a great job of using their staff in new ways. So the medical assistant will call the patient when their appointment's going to be in 10 minutes. So they're not left waiting online on hold with a black box, but that takes staffing flexibility. And then there's the wonderful point in the comment from Lori that I really want to highlight, that community-based organizations have solved for this in their own ways. And we need to make sure to tap that. So I just think that's a charge for everyone on this panel, but also for the audience, to just assume that there's a solution out there potentially that you could learn from, and just keep looking for it, because we're all trying to solve the same problem. And so it's just important. I worry about recreating the wheel with a lot of this, and there's a lot out there.
Wonderfully put. Maybe we could keep that theme going as time draws down. For some closing remarks, any key takeaways that you'd like to share before we close up?
So I will,
Mario,
go ahead, William.
yeah, so in terms of the work that the equity committee is doing, are they looking at the big pictures? I mean, I think what we're talking about is, getting people in front of a screen so they can do a telehealth visit, right? And how that can be effectuated, most effectively. But the reality of it is that so many people still don't have access. They don't have computers. They don't have broadband. So who is the equity committee an advocate and also tackling that issue at that level? Because I think all of this is great, but particularly for the minority community, the Central Harlems of the world and other places, right. This conversation is not relevant unless folks really have access and hands-on training to use the technology, which Absolutely. I think we all can agree, we are never going back to what we used to be as a world. That's done, right? If you still think that we're going to go back to the way things were, then someone needs to bust that bubble. And I'm not being anything personal, but we're going forward more and more. In my computer training classes, my instructors now not only are getting hands-on training, sometimes basic, but they're teaching folks how to do Zoom. They're teaching folks how to communicate with their children. They're teaching people how to navigate these government systems that are now more frequently going to online services. Social Security is one. I mean, it's almost like everything you have to do with Social Security is online. And so many folks really just don't know how to navigate that. So again, training, access, and equipment are really fundamental to making sure there's broad-based equity across the board.
Thank you, William. Darcy, you were gonna share?
I think it's thinking about equity and thinking about the access to equity. I also want us to think about, we focus a lot on the patient perspective, and I think that's great. And I'm pleased to hear Dr. Weisman's all ready for all day telehealth sorts of things, but I think we also have to think about our healthcare providers, because I know those of us who are doing meetings and we're going from Zoom to Zoom to Zoom to Zoom, I know what fatigue that can cause. So I want to make sure that we're not trading one burden for another. So I think that's, again, just something that we have to keep in mind as we move forward, thinking about the mental health and just plain sanity at this point, I think, of our healthcare providers across the board, to make sure that they can continue to be there and provide the amazing services that they do, whether that be in person or virtually. So again, just thinking through strategically about that opportunity and what that means for everyone who is a part of the.
It's a good point. Great point.
Absolutely. And Matt, do you want to close us out?
Yeah, I mean, I thank you for, thanks again for having me and for this really stimulating discussion. I agree with all those things that people said. I think as we think about digital health, my only other thing would be to sort of think more broadly than just video visits. I think as Dr. Knudsen said, the like, you know, counseling navigator piece also, like who else can do video visits, but also what other kind of technology is there? You know, we use a lot of e-consults, which is to say asynchronous doctor-to-doctor communication as a way of saving a patient a visit to a specialist and have the primary care doctor get feedback. There's lots of remote monitoring and all these other technologies that sometimes don't require a lot of digital interaction from the patient side. So somebody who's not very digital literate can still have an e-consult sent about them to a specialist, still get their feedback from a PCP, can still wear a monitoring device. And so thinking about all those other technologies that are a piece of this, that we can use to help complement the video visit or the in-person visit, I think is part of like this future of primary care.
Terrific. No, so many good points, so much to think about, tons of opportunity and potential throughout all of this. As we, as William said, look forward, because we're not going back to the old models. So we are 3 minutes over. I wanted to thank all of our panelists for sharing their expertise and their time with us. Also, thank you to the ACL for all of their support. And I wish you all a lovely rest of the week. Thanks for joining us.